Hi, my name is Vince Raikhel and I'm a hospitalist here at the VA in Seattle. I'm here to talk to you about altered mental status, and by the end of this Chalk Talk you should have a framework for organizing your differential diagnosis, diagnostics, and therapeutics to manage an acutely altered patient for the first 10 minutes of a rapid response. So let's get started. So you're going to jump into your room with a patient who's having a rapid response. What is the first piece of information you're going to want to gather?
Their vital signs.
Their vital signs, exactly. This is super critical and helps you triage what type of rapid response this is. Is this going to be a hypotensive patient, and a patient with arrhythmias, a patient in respiratory distress, or just a patient with an altered mental status rapid response? It can be very helpful. In addition to the vitals, what's the other key piece of information you're going to want to gather in terms of when you're assessing your patient?
The ABCs.
Exactly, the ABCs. Super critical because you want to know, was this a rapid response or should this actually have been a code? And when you're doing that, the reason is you're going to want to assess who is in the room and who do you need to support you. And so you're going to want to call for help early on when you're doing this. Let's say you are getting your vital signs and you notice that the respiratory rate is low. When we have a low respiratory rate, we're going to have a low threshold to be getting a blood gas, a VBG or ABG. And what are we going to be looking for on those blood gases?
Elevated CO2.
Exactly. So we're going to want to be seeing if our patient has hypercarbic respiratory failure. This is going to be the first of our 5 diagnoses that we need to rule out in the first 10 minutes of this altered mental status rapid response. In a patient with hypercarbic respiratory failure who's hospitalized, what group of medication are we concerned about that they may have been getting too much of?
Opioids.
Exactly. And so if we're concerned about this, we're going to want to have a really low threshold to give them naloxone. We're going to want to give them 0.4 milligrams of naloxone IV to support them. And you want to think about this as not only a therapeutic but a diagnostic test. If we give a lower dose of this, then we wouldn't be necessarily sure if it was the wrong diagnosis or we just didn't give enough. So give a big dose of naloxone to rule out or to treat an opioid overdose. Okay, so going back to our framework, you go into the patient's room, you're getting your vitals. What is the first lab you want to gather for a patient who is acutely altered?
A blood sugar.
Exactly, a point of care glucose. Super useful and helps us determine whether this was iatrogenic hypoglycemia, which is another incredibly common cause of an altered mental status presentation for a hospitalized patient. If the sugar is less than 55, we're going to want to give dextrose. Either 50 cc's of D50 or 250 cc's of D10. After we give this, we're going to want to be checking the sugar pretty frequently because this is going to be a short-acting intervention. And so after you administer this, make sure that you're working with a nurse to check another point of care glucose every 15 to 30 minutes until you have stability. Okay, let's go back to our framework. So after we've gotten our vitals and we've done our point of care glucose, we're going to want to get the story. So what are some of the key pieces of information that you want to learn about either the situation or the patient more broadly?
I think the past medical history and maybe more about what happened.
Exactly, past medical history, like what occurred, and in that I want to add, like, when was their last known normal? Were they acting like normally earlier in the day, or has this been a more kind of subacute change throughout the day? You also want to know what is their baseline, right? In addition to that, as we mentioned earlier, medications can be super critical in terms of this assessment. And then also, did they have any procedures today? Did they go to the OR and get a lot of sedating medications? Another really common cause for patients to be altered. Okay, now after this, we want to focus on the exam. And I do want to stress that the rapid response physical exam is going to be a super focused skill. is something you want to practice so that you can get the key information that you need within 30 to 45 seconds and then be able to make decisions on that. And so we're not doing a nose to toes exam, we're going to be doing a more focused physical exam. What are some of the things that you're going to want to focus on in your focused physical exam for a rapid response?
Definitely heart and lungs, and then mental status, or neuro exam.
Exactly. So heart and lungs for all the patients. I think a mental status exam, it's a kind of a Gestalt GCS exam, is super critical, and for my money, probably the most important in terms of triaging my concerns for a patient, regardless of the category of the rapid response we're in. And then I love what you said, like a global neuro exam. We're going to want to be able to see whether there are any major focal deficits. We want to be able to assess these things quickly. And I would just add on to this extremities. I think it's a very easy thing to be able to assess and just be able to like see whether somebody is cold, warm, edematous, anything like that. Okay. When we're going through this, let's say we go through our framework, and what we're going to do now is think about 3 more diagnoses that we need to rule out to be able to make sure our patient is safe in this setting. So let's say we go through this, we're doing our exam, and we're doing our neuro exam, and we notice that there are focal neurodeficits. The patient is unable to move half their body. What are we most concerned for?
A stroke.
Exactly. So we're concerned for a stroke at this point. And what should be your main instinct? You do the exam, you're concerned for a stroke, what do you need to call?
A code stroke.
A code stroke, exactly. Code stroke is going to get you a lot of things. It's going to alert the neurology team, the stroke experts, in terms of the care that's needed for your patient. And it is also going to reserve the CT scanner for your patient, which will be super important for when they get down there. Speaking of which, what imaging studies do you want to order for your patient immediately?
Non-contrast CT of the head and a CTA of the head and neck.
Exactly. We're going to order that as well as 1 lab. And we're going to want to order coags. The reason is for those neurology team to be able to make the decision they need, which may involve the giving of TPA to your patient, they're going to need coags to help support that decision. So you want to order that right off the bat. Okay, let's go back to our framework. We're doing our physical exam. We're looking at our patient in their neuro exam. The eyes are fluttering. We're seeing some rhythmic motion. What should be at the top of our differential?
Seizure.
Exactly. Now, seizures can be kind of insidious in how they present, but it is another common cause of altered mental status. You're concerned for a seizure. What would be a medication that you would want to be ordering?
A benzodiazepine.
Exactly, a benzo. Midazolam or lorazepam. Lorazepam, 2 to 4 milligrams. You're not going to want to give this immediately. Most of these seizures will abort on their own. If the patient is still seizing after 5 minutes, you're going to want to give them lorazepam. You're going to want to make sure that they're safe in the environment that they're seizing in and not actually hurting themselves. You're going to want to call neuro, order an EEG. Now let's say we go through our framework. We're not concerned for an opioid overdose. We're not concerned for hypoglycemia based on the point of care glucose. We did our neuro exam, no evidence of a CVA, no evidence of a seizure, basically a non-focal exam. What I want you to be concerned about in this setting would be sepsis. Sepsis may present in your patient who is altered, and it could be the canary in the coal mine telling you that there is a brewing infection, a bacteremia, something is going on in a patient who doesn't have a fever, who doesn't have a white count, that they may be septic. And so if you go through this framework and nothing is coming up as clear, have a low threshold to invoke sepsis, do a broad infectious workup, and consider starting broad spectrum antibiotics. Okay, so stepping back again, when you get into your room with your altered patient, make sure you get your vitals and do your ABCs, and then think about these 5 diagnoses of a acutely altered hospitalized patient: opioid overdose, iatrogenic hypoglycemia, seizures, strokes, and if all of that is negative, sepsis. I hope this was useful. Thanks very much.
Thank you, Dr. Raikhel.